schizophrenia. Schizophrenia affects 1% of population worldwide due to many possible combination of symptoms. Schizophrenia as a diagnostic entity has been criticized as lacking its scientific validity and reliability. Different approaches have been used to overcome this difficulty, of which descriptive psychopathology has been most accepted. Snyder stressed the usage of symptom and sign as prime variable in the clinical diagnostic practice. Pointed out certain symptoms as being characteristic of schizophrenia and therefore exhibiting a first-rank status in the hierarchy of potentially diagnostic symptoms. Contended that they should have decisive weight beyond all other in establishing the differential typology between schizophrenia and cyclothymia, did not attempt to relate them to a theoretically concept of the underlying mechanism in schizophrenia, attempted to determine to what extent his diagnostic approach to mental illness could be applied with confidence. Reviewed the case record of almost 3,000 patients, diagnostic certainly was achieved in more than 98% of the cases. First rank symptoms play important role in the recent diagnostic symptoms like ICD-10 and DSM-3, 4, 5. Presence of one first rank symptom is symptomatically sufficient for the schizophrenia diagnosis. Critics claim that first rank symptom may also be encountered in the non-schizophrenic condition, non-specific or diagnostic for schizophrenia. Concept how it is evaluated. Evaluation. Emil Kraepelin in pioneered by psychiatric nosology, first separated organic psychosis, described two major groups of primary psychotic disorder, manic depressive psychosis, dementia precox. Long-term prognosis and course of illness as principal feature. Dementia precox course was deteriorating and irreversible. Believed loss of inner unity of the activity of intellect, emotion, and volition. Included a broad group of disorder known as separately at that time. Paranoia, catatonia, and hyperphrenia, subtypes of the same illness. Again, Bleuler introduced term schizophrenia in 1911, denote a splitting of psychiatric function considered to be the core feature of the illness. Much more concerned with the understanding of the psychological mechanism underlying the disease process. Consider the loss of harmonic coordination among thought, emotion, and behavior to be the hallmark of illness. Primary and secondary symptoms. Primary are 4A's: abnormal association, autistic behavior and thinking, abnormal affect, and ambivalence. Hallucination, delusion, and social withdrawal and diminished drive, secondary manifestation of illness, dependent on the adaptive capacity of the individual and environmental circumstances, saw the symptom as a continuum with normal behavior. Snyder attempted to make the diagnosis of schizophrenia more reliable, so-called first-rank symptoms. The presence of one of these symptoms in the absence of intoxication, brain injury, sufficient for making the diagnosis of schizophrenia. When any of these modes of experience is undeniable present and no basic somatic illness can be found, we may make the decisive clinical diagnosis of schizophrenia. Characteristic of first rank symptom. Must occur with the reasonable frequency in schizophrenia, must generally not occur in coordination condition other than schizophrenia, must not be too difficult to decide if the symptom is or aren't present. First rank symptom, malware. Here, auditory hallucination, audible thought, voices heard arguing, voices heard commenting on one's action. Thought disorder, passivity of thought, thought withdrawal, thought insertion, thought broadcasting. Passivity experience like delusion of control, made affect, made impulse, made volition, somatic passivity, delusion, delusional perception. Similar to echo, dalapancy, conard, hallucination before the thought, or the patient perceives the voice and almost immediately has the experience that the content of the hallucination of is his thought. Crippling auditory hallucination might occur either before or after the thought. Patient may hear people repeating his thoughts aloud after he has thought them, answering his thought, saying aloud what he is about to think. Thought echo. Example is a 35 years old painter heard a quiet voice, which he could equally hear in both ears. The voice will say, I can't stand that man. The way he holds the brush, he looked like a fool. He is immediately experienced whatever the voice was saying as his own thoughts with exclusion of the other thoughts. Voices are being two or more hallucinatory voices are in disagreement or in discussion. The subject is usually the patient who is referred is third person. Example here is 25-year-old male reporter hearing voices. One voice deep in pitch repeatedly said, "GT is bloody paradox." Another higher is pitch. He is that he should means he is that voices is discussing among themselves about patient. Voices commenting on one's action. Description of patient activities as they occur. 41-year-old lady heard a voice instantly in a flat monotone. She's peeing in the potato. Got hold of the peeler. She does not want that potato and putting it back because she has a dirty mind. Thought withdrawal. Thought are taken out of the mind as the thought sees. He simultaneously experience them being withdrawn by some external force. Here example is 22 years old woman. I'm thinking about my mother and suddenly my thoughts are sucked out by a vacuum evacuator and my mind is empty. Thought insertion. Here, a patient thinks that somebody put forcefully thought in their mind. Thought insertion into the person's mind by some external agent. Thought are unfamiliar, result in self-image, disturbance and affects boundary in between what is self and what is not self. A 25-year-old lady said, I look out of the window and I think the garden looks nice and grass looks cool, but the thought of Andrews come into my mind. There are no other thoughts there, only his. He treats my mind like ice cream. Thought broadcasting. Sense that the person's thought are experienced as real phenomena by others. Thought are made audible or may be experienced by others through telepathy. Content of the patient mind is no longer private. However, how depends on background, culture, predominantly interest. Here the example is a 21-year-old student said, as I think my thoughts leave my head on a type of mental ticker tape. Everyone around has only to pass the tape through their mind and they know my thoughts. Now, what is passivity of affect? Feeling that are not a person's own are imposed on that person by an external agent. Patient believes he has been made to feel it by an external source. Here the example is a 23-year-old female patient reported, I cried, tears rolled down my cheeks and look unhappy. But inside I have a cold anger because they are using me in this way. And it is not me who is unhappy, but they are projecting unhappiness onto my mind. Passivity of impulse. An impulse for action is imposed on a person by some external agent, usually overcomes the patient to which he almost invariably gives way. Impulse may be experienced without subject carrying out the act. If carried out, action is admitted to be patient owned, not the impulse. Here again, a 26-year-old engineer emptied the content of a urine bottle over the ward dinner trolley. He said, the sudden impulse came over me and I must do it. It was not my feeling. It came into me and from the X-ray department. That was why I was sent there for implants yesterday. It was nothing to do with me. They wanted it done. Passivity of volition. Person actions are from and are controlled by external agent. The person is passive participant in the action. The movements are initiated and directed throughout by the controlling influence, and the patient feels he is automation, the passive observer of his own action. Here, again, one example is 29-year-old uh, typist describe her action as when I reach my hands for the comb, it is my hand and the arm which move and my finger pick up the pen, but I don't control them. I sit there watching them move and they are quite independent. What they do is nothing to do with me. I am just a puppet who is manipulated by cosmic string. Another one is somatic passivity, tactile or visceral hallucination that are imposed by some external agent can be combination of different somatic hallucination, delusional belief, body influence from outside uh, the self may also occur in association with a normal person. Here, a 38-year-old man had jumped from a bedroom window, injuring his right knee, which was very painful. He described his physical experience as the sunrays are directed by US Army satellite in an intense beam which I can feel entering the center of my knee and then radiating outward, causing the pain. Delusional perception. Type of primary delusion. Perception that has a unique and idiosyncratic meaning for a person, which lead to an immediate delusional interpretation. New meaning cannot be understood as arising from prevailing affect state or previous attitude. Here is one example. These are the first rank symptoms by Schneider's audible thought, voices arguing or discussing, voices commenting on patient action, somatic passivity, thought withdrawal, thought insertion, thought broadcasting, made feelings, made impulse or drives, made volitional acts, delusional perception. These are first rank symptoms, present state examination equivalent. These are the number of patients experiencing the first rank symptom. Total 100 cases was there in a study. Assessment problems require considerable clinical experience. Must know the first rank symptom first. must know how this person from the social and racial background is likely to describe any particular first-line symptom. Means patient verbatim how he described in local language. Must ask appropriate direct questions skillfully. Must be able to interpret patient answer. There is one study called IPSS, International Pilot Study of Schizophrenia, sponsored by the WHO. 1200 interviewed using the present state examination showed that schizophrenia manifests itself in similar way across very diverse culture with similar rates of hallucination and delusion. First line symptom and affective symptom among people with schizophrenia in developing and developed countries. These are some diagnostic criteria. In ICD-10, greater emphasis on Schneider's first line symptom. In ICD-10, corresponding to first line symptom, thought echo ABC is same having the same first line symptom criteria type. A is thought echo, thought insertion or thought withdrawal, and thought broadcasting. B is delusion of control, influence, or passivity, clearly referred to body or limb movement. C is a hallucinatory voices giving a running commentary on the patient behavior or discussing the patient among themselves. Other classification incorporating first line symptom is research diagnostic criteria, Figner's diagnostic criteria, New Haven schizophrenia index, St. Louis criteria, present state examination in IPSS study, diagnostic value of first rank symptom, four critical issues, the sensitivity of the symptom to be the condition. Second one is their specificity. Third one is the variability. Fourth one is their status as a gold standard. The frequency of first rank symptoms in schizophrenia are diagnosed by the research diagnostic criteria. The forerunner of DSM, early DSM version themselves and other schedules varied between 28% to 72%, on an averaging 50%. The frequency of first rank symptom in psychotic depressives is very low. There is a considerable variation in how each first rank symptom is evaluated among authors. The investigator who must emphasize Meller found the higher rate of first rank symptom in schizophrenia. Validity was assessed either by the extent of intercorrelation between the individual first rank symptom or by their persistence over time. Seen first rank symptom episode by episode noticed. A sensitivity of nearly 3/4 in two studies. There are some theories. We know of first rank symptom deficit in the integration of the self, leading to a loss of ego boundaries. Local dysfunction like Trimble suggested first rank syndrome indicate temporal lobe dysfunction. Genetic studies show hereditability of 0. These are some inadequate damping of non-dominant hemisphere activity thought elimination phenomena. Neuropsychological currently has the most evidence, mainly based on the work of Christopher Frith, divided the symptom of schizophrenia into three broad groups: disorder of build action, disorder of self-monitoring, disorder in monitoring the intention of others. According to this theory, deficit is self-monitoring lead to a loss of sense. There are some imaging studies show the hyperactivation of right inferior parietal lobule and cingulate gyrus. Dysfunction of brain areas involved in space and body represented implicated. may involve prefrontal, parietal, and prefrontal temporal network. These studies show the first rank symptom prevalence. First rank symptom in psychiatric disorder may be seen in organic brain dysfunction, schizophrenia, mood disorder, personality disorder. These are some studies showing the prevalence. All are these studies, Indian research showing by the Nimhans. Criticism. Inherent problem. Most classification, especially ICD-10, need first and symptom for diagnosis is in most cases how to test validity of the symptom when diagnosis is made on that symptom. Unreliability of assessment. Flaws in Schneider's original work, diverting attention from other core symptoms. Present day status, presence of or absence of first rank symptoms does not alter the specificity in the diagnosis of schizophrenia. Conclusion. Schizophrenia is an entity still controversial. First rank symptom noticed to help simplify diagnosis. FRS is characteristic of schizophrenia in the absence of clear organic etiology. DSM-5 places less importance to its compared to ICD-10 of first rank symptom. Thank you.